All right, Ninja Nerds, so we're going to continue on talking about shock, but we're going to focus right now about distributive shock. So if you remember, we talked over there about how certain situations like hypovolemic shock and cardiogenic shock and even obstructive shock were causing this decrease in blood pressure. And it was really due to a decrease in cardiac output. They weren't able to get enough blood flow out into the actual circulation. So the volume that was being distributed in the circulation was actually low. In distributive shock, it's not really due to that type of issue. It's actually due to a decreased tissue perfusion due to a decreased systemic vascular resistance. So you guys remember we wrote over there that we said that this low BP could be due to two different types of things, right? One is it could be due to a decrease in our cardiac output or a decrease in the systemic vascular resistance. Most of the shocks that we talked about over there were due to this situation, a decrease in the cardiac output. They weren't able to get enough blood flow to the peripheral circulation. Now, for distributive shock, the blood vessels are so expanded and dilated that now the systemic vascular resistance is actually going to decrease. So the problem with these vessels is that the vessels are extremely dilated, they're expanded. And because they're so dilated, it's going to decrease the tissue perfusion. And if you decrease the tissue perfusion, you decrease the oxygen delivery, that hypoxia progresses to ischemia, ischemia progresses to necrosis of the tissue, and as the tissue starts dying, the organ starts failing if not treated. So let's go ahead and see now how septic shock displays that type of activity. All right. So first thing, you can see my little goldfish-like looking microbes in there, right? Cute little guys, but dangerous. Let's just pretend that this microorganism here is some type of dangerous gram-negative bacteria. Okay, let's pretend it's some type of dangerous gram-negative bacteria. You know gram-negative bacteria, what's so dangerous about gram-negative bacteria? They have these things called endotoxins, which are like those lipopolysaccharides. And what happens is these guys can release those endotoxins. And these endotoxins can cause so many different types of problems. Okay, gram-positive bacteria, just understand that they can release chemicals that are similar to endotoxins, okay, but they're not endotoxins, and release even some certain fungi. Even certain fungi can actually release certain types of chemical modulators that act like endotoxins, but they are not endotoxins, just so we're clear. So gram-positive and fungi can cause the same type of septic shock as gram-negative. It's just a little bit more common with the gram-negative. All right, so what do these endotoxins do? Why are they the culprits of all of these problems? Well, let's go ahead and see. So and we're going to move through this briefly. If you guys have watched our video on the inflammation, the inflammation part 1, part 2, part 3, part 4, that will really help you out because we're basically going to have a little quick recap of that, super quick. So what are these endotoxins doing? If you remember, they were damaging the tissues. And as they start damaging the tissues, our tissues are starting to release certain chemical mediators. Remember those certain chemical mediators they're releasing, like prostaglandins? They're releasing chemicals like prostaglandins and leukotrienes. Leukotrienes are some of those actual lipid mediator like messenger molecules that were broken down from arachidonic acid. These guys here are coming over here and stimulating certain cells in this vicinity. What are these certain cells? Some of these cells here are called mast cells. And when these mast cells are stimulated by these chemicals, they start releasing out a lot of different types of chemical mediators. So they can start releasing like histamines. They can also release leukotrienes. They can also release prostaglandins. They can even release other different types of chemicals like proteases. And they can even release certain types of chemotactic agents. Why is all of this bad? It sounds like there's just a lot of inflammation. Well, guess what? Let's see here. Whenever you're releasing a lot of histamines, a lot of leukotrienes, a lot of prostaglandins, these start coming over to the blood vessels and dilating the blood vessels. So they dilate the blood vessels and they make the blood vessels really, really leaky. What is that called whenever you make the vessels really, really leaky? You're increasing the vascular permeability, okay? So as a result of this, what are we going to do to the blood vessel? We're dilating the blood vessel so it's going to get bigger. So the vascular resistance is going to decrease. So as a result here, we're going to do two things. We're going to vasodilate the blood vessel, and we're going to increase the permeability, the amount of leakiness. If this happens due to the fluid leaking out of this area into the actual interstitial spaces and stuff like that, why is that so dangerous? Because that fluid can start accumulating a lot into these tissue spaces. As the fluid starts accumulating a lot into the tissue spaces, what starts happening to the blood volume? the blood volume starts decreasing. As blood volume starts decreasing, this leads to a proportional decrease in the blood pressure. That's why this is dangerous, okay? What else can happen here? These chemotactic agents are going to try to signal our immune system. They're going to be like, yo, immune system, come out here. So they're going to try to call out the monocytes. You know, we have monocytes in here. We even have some neutrophils. These guys are going to try to fight off this bacteria. And it's due to these chemotactic agents. These chemotactic agents are going to pull them out. What else gets pulled out to this area? Complement proteins. You guys remember the complement proteins like C3 and C5? They were those little guys that actually had to get activated by these proteases. So when C3 and C5 come over here, these proteases released by the mast cells activates these C3A and C5A. And these guys help to be able to do a couple things. They actually stimulate the endothelial cells to become very, very permeable. And they'll cause some other things to be released as well. So they're going to increase the permeability, and they're actually going to enhance the inflammatory response. They're also going to play a role in chemotaxis. So far, what do we know? The endotoxins are damaging the tissue, causing chemical mediators to be released, stimulating the mast cells to release a ton of different chemicals like histamines and leukotrienes and prostaglandins, dilating the blood vessel, increasing the actual permeability, causing more things to leak out. It's also releasing chemotactic agents that draw a lot of white blood cells to the area. And it's going to cause the complement proteins like C3 and C5 to get activated, which can activate the endothelial cells to start dilating and also increasing the immune response. And it's going to cause more white blood cells to come to the area. Now, when these white blood cells come over and start trying to fight off this endotoxin, look what happens here. These actual white blood cells will come over here. Let's say that we have a monocyte here. And it's got this gram-negative bacteria over here that it's trying to fight off here. So there's that like little bacteria. Where was our little? Let's actually draw it like this. Here's our little bacteria right here. And it's trying to fight off this bacteria. Whenever it comes into this area and it starts trying to fight off the bacteria, it starts releasing a bunch of chemicals. Some of the chemicals are going to be like interleukin-1, tumor necrotic factor alpha. You're even going to have a lot of other chemicals released like interleukin-6, interleukin-8, a lot of different substances. What's the whole situation with this? Interleukin-1 and tumor necrotic factor alpha, if released in significantly high amounts, they're going to go to your hypothalamus. So these are going to go to the actual hypothalamus, in a specific area in the hypothalamus where the actual temperature regulation is occurring. And when they go to the hypothalamus, they're going to reset the actual hypothalamic temperature system. And this is going to lead to the release of PGE2, which is a prostaglandin. And this prostaglandin is going to change our thermometer, our body's thermometer readings. And it's going to cause us to develop an increased body temperature, very high body temp, but we don't call it this. We say it gets so high that we actually develop a fever, okay? We start developing a fever. So that's one of the things that you're going to notice about septic shock. They're going to develop a fever. They're going to have really dilated blood vessels, a lot of permeability, a lot of inflammatory cytokines released. You know what else happens? It's interleukin-6. It also goes to your bone marrow. In your, I'm sorry, not your bone marrow, it goes to your liver. You know your liver is responsible for producing a lot of different types of proteins. One of the really important things about the liver is actually going to respond to this interleukin-6, and it's going to produce a lot of these things called acute phase reactive proteins. So acute phase reactant proteins. And these proteins are going to be like C-peptide and haptoglobin and ceruloplasmin, a whole bunch of different proteins that basically are an indicator that there's a lot of inflammation going on. Okay, a lot of inflammation. That's really bad. What else? Interleukin-8 can actually go and signal other white blood cells to increase their actual phagocytic activity so that we can come out and start eating out more bacteria. So this is going to cause the actual white blood cells to increase their phagocytosis processes. Okay, and it's going to increase chemotaxis too. So now what else can these endotoxins do? You know, they're really mean. These are really mean suckers sometimes. They can actually come up to our endothelial cells and do two things. One is they're going to tell the endothelial cells to increase the expression of what's called a plasminogen activator inhibitor type 1. Why is this bad? Because you know there's an enzyme, you know there's a process here called plasminogen, and plasminogen gets converted into what's called plasmin. And plasmin likes to break up the clots. It tries to cause fibrinolysis. Well, this is carried out by TPA, tissue plasminogen activator. If you increase the expression of plasminogen activator inhibitor, what do you think you're going to do? You're going to inhibit this guy right here. the tissue plasminogen activator. He can't activate plasmin. As plasmin levels start decreasing, you aren't able to break up the clots. So what does that mean then? I'm going to develop actually some clots. So I'm going to develop some microvascular occlusions. This is bad. If I start developing like right here, a microvascular occlusion, okay? So a thrombus basically. And it's not getting broken down, I'm going to start affecting the blood flow beyond that area to the tissue. What's the problem with that? That can lead to ischemia. So this can add to the ischemic problem. So we already have a problem getting oxygen to the tissues because the vessels are so vasodilated. Now we just added to the problem by actually causing this thrombus to actually develop. And this microvascular thrombus is actually decreasing the blood flow to the tissues, causing ischemia. Another thing that can happen is the endotoxins can actually increase the expression of another type of protein. These little suckers are little mean guys. They increase the expression of these proteins here on the membrane. And these proteins here are called tissue factor. And tissue factor is really important because it helps to generate the actual coagulation cascade. So if you increase the actual expression of this tissue factor, then what's going to happen then? If you have a lot of this tissue factor, you're going to increase this whole process of where you're going to have a lot of these clots developing here. So increasing the expression of this tissue factor is going to add to the problem and causing a lot more blood clots to be affected because you're increasing the coagulation activity. This also leads to another problem. Because of increasing the PAI, the plasminogen activator inhibitor, that's inhibiting this, causing microvascular occlusions. Tissue factor is also causing this microvascular occlusion by increasing the coagulation activity. If this happens in various parts of the body, okay, which can happen in septicemia with a septic shock, right, is that it can lead to what's called disseminated intravascular coagulation, what's called DIC. And DIC is terrible. It's where you actually bleed because you're consuming so much of your clotting proteins. You have so many different widespread blood clots throughout the body that you've consumed almost all of your clotting proteins, and when you need to clot, you can't clot. And these people start bleeding from like different orifices, like from their eyes or from their mouth or from their ears. It's terrible. So that's also another problem that can happen here. Another thing that can happen here is not only have we developed, what have we developed here so far? We've developed a fever with these people. They've increased the production of the acute phase reactant proteins. We've actually caused a lot of vasodilation, a lot of permeability, which is leading to what? That's leading to a decrease in the blood pressure because we're losing a lot of volume here. And this is the big problem here because we're not getting enough oxygen to the tissues and they're becoming ischemic and then possibly necrotic. We're causing a lot of microvascular occlusions by increasing the PAI production and by increasing tissue factor. Guess what? There's even other things. You know our white blood cells, or they're called the neutrophils? Whenever they're trying to fight off these bacteria, sometimes what they'll do is they'll release certain chemicals to try to fight it off. One is they'll release what's called reactive oxygen species. Unfortunately, though, they release so much during this time period that it actually starts damaging the actual endothelial cells. As he starts damaging the endothelial cells, guess what happens? According to Virchow's triad, he says that one of the things that can increase hemostasis or blood clots is whenever there's endothelial cell dysfunction. Guess what can start happening? You can start developing increased incidences of thrombi. So that's another problem here, okay? So a lot of things are going to happen here within this individual, and you want to make sure that you understand how this whole process is working, okay? So another situation is there's going to be the production of ROS, the reactive oxygen species, and even other things which are called extracellular traps, which is like basically histone proteins with a little bit of DNA that are released onto the actual circulation to bind onto bacteria and try to tag them. But this is kind of the big thing. One other thing that I want to mention, the last one here, is interleukin-1 and tumor necrotic factor alpha and some of these other interleukins. They can have another devastating thing that they can do. They can actually cause the depression of the heart function. They can actually depress myocardial contraction. This is bad. And how? One of the things that happens is because you're not getting enough oxygen delivery to the tissues, you start developing a lot of lactic acid. And a lot of lactic acid can actually cause a lot of problems here. So not only is the lactic acid one of the problems of decreased myocardial contractility, but also these interleukins like interleukin-1 and tumor necrotic factor alpha, they also have a depressive activity on the myocardium of the heart. So that's also going to add to the problems though. But here's what's really weird. Here's what's really weird, getting to the bottom of this. When these individuals who have septic shock, because of all these different problems, their blood pressure starts dropping, right? Their blood pressure starts decreasing. When their blood pressure starts decreasing, their BP is decreasing. It's really due to what? These blood vessels really dilating and increasing their permeability. That's another thing that this interleukin-1 and tumor necrotic factor alpha also can do. They can also come over here and also contribute a little bit to some vasodilation activities, and so can interleukin-6 and 8. There's a lot of different things here. But the whole idea here is that vasodilation is actually going to be causing the blood vessel to get a lot bigger. As that happens, that decreases the systemic vascular resistance, right? So this is decrease in systemic vascular resistance due to the vasodilation causes that decrease in blood pressure. And that's what's really dangerous. What's weird is that these individuals who have septic shock in the early stages, they actually have a high cardiac output, okay? And so that's one of the weird things that can happen in these people, and it's because even though it's actually affecting some of the volume and the return and depressing the myocardial contraction, the ventricular walls are actually getting thinner, so it's kind of compensating for that, and because of that, it's helping to maintain a decent cardiac output. So in these individuals who are in septic shock, just watch out because they have an increase in cardiac output, a decrease in systemic vascular resistance. They also have a decreased blood pressure, hypotension, and obviously they can have a fever, they can have acute phase reactive proteins being produced, they can have increased incidences of microvascular occlusions, which can lead to DIC, can lead to a lot of different problems. It also can lead to ischemia too. So very dangerous situation here. Now the thing is, how would you treat this person, okay? You treat this person right away by putting them on antibiotics. You're definitely gonna wanna do an IV antibiotics. That's obviously the most important thing that you're going to want to do with this situation is you're going to want to put them on IV antibiotics. Okay? Now the question is okay, well, Zach, what if I don't know what type of bacteria they're on? That's when you have to send out a culture. So you obviously have to do a culture. But even if then, you can put them on broad spectrum antibiotics. Like you can use what's called Ceftriaxone. Okay, so you can use Ceftriaxone and you can combine that with what's called Zosyn, which is basically what's called pip-tazo. It's piperacillin and tazobactam. And you can use these as a combination for the broad spectrum. And then once you figure out, oh, they actually have an intra-abdominal infection, okay, we'll put them on metronidazole and maybe some type of clindamycin. Oh, well, they don't have a spleen. Okay, we'll put them on ceftriaxone to prevent them from being infected by Neisseria meningitis or Streptococcus pneumoniae or Haemophilus influenza. So obviously, again, the whole point is do a culture, but first thing that you want to do is put them on broad spectrum antibiotics, and not just the antibiotics, what else would you want to put them on? They're losing some of the fluid into the tissue spaces. Give them fluids. So another thing that you're going to want to give these people is you're also going to want to give them fluids. So try to give them some actual fluids. So put them on crystalloids, right? So give them certain types of, like a Ringer's lactate. So give them like a normal saline or a Ringer's lactate. Also, if they're not responding to the fluids, you might have to put them on vasopressors. So if you give them fluids and they're not properly responding to the actual fluids correctly within over a certain amount of time, you can give them vasopressors to help to be able to constrict the blood vessels and get some of that actual volume circulating again. But big thing is treat the underlying issue, which is going to be giving the antibiotics. And then again, if it's certain types of bacteria, obviously treat for that. So for example, if it's like MRSA, give them vancomycin. If it's some type of situation like a Pseudomonas, give them gentamicin. Obviously, make sure that you find out the type of bacteria. But before that, put them on broad spectrum antibiotics. Give them fluids and try to be able to restore their blood pressure. That's how septic shock is going to work. Okay? Let's go on to the next one, anaphylactic shock. Anaphylactic shock is just basically an allergic reaction. It's a severe systemic allergic reaction. So really important for this one, it's basically an allergic reaction. And this one, usually it's due to a first exposure. So let's just say that you hear most people, if they take penicillin, like they have a penicillin allergy, or some other type of drug, like maybe morphine or codeine, they break out and they can go to anaphylactic shock. There could be a lot of different causes. A lot of it could be even bee stings, like certain insect bites, like bee stings, or even like certain like bugs that actually, certain insects that can actually bite, the venom within them. Could even be due to like food allergies. Some people may be severely allergic to certain foods. So food allergies, drug allergies. You know what else is another one? You know when sometimes they have to put contrast into the individual to look at the certain situations, they do it IV. Certain types of IV contrast, people can actually have a severe allergic reaction to. So the whole point here is it's a severe allergic reaction. It could have many different types of causes. But what's the whole idea here? let's say that I'm exposed to this allergen at first, because usually you don't go into anaphylactic shock off your first exposure to it. But let's say that here's the allergen. Here's the allergen. And I'm exposed to this allergen the first time. Usually what happens is this allergen is going to get processed by like certain cells, like maybe my macrophages. And whenever this macrophage is actually encountered by this allergen, it's going to express that allergen on its membrane with an MHC2 complex, right? So it'll express it on its membrane with an MHC2 complex. And then what it will do is it'll take it to a T cell. So it'll take this to a T helper cell. This T helper cell will then have specific proteins on its membrane, like a target cell receptor, and it'll have another different type of protein expressed on its membrane too. So it has a lot of different proteins on its membrane. So this is actually going to be like a macrophage. So this could be like a macrophage. And what happens is this macrophage is bringing the MHC2 complex as well as bringing here this antigen. When he comes, he'll bring it to this T helper cell, and the T helper cell will have a TCR, and it'll also have another protein here called a CD4 molecule. When these guys interact, the T helper cell responds to this and starts producing certain types of chemical mediators. These chemical mediators that it's going to start releasing could be various different types of interleukins. Okay, it could be like interleukin 2, interleukin 4, interleukin 5. The whole purpose is it starts releasing tons of cytokines. These cytokines come over here and stimulate another cell. This cell is called a B cell. And what it'll eventually do is it'll convert the B cell. So let's say here's our B cell. It'll convert it into what's called a plasma cell. This plasma cell is really important because what it'll start doing is it'll start secreting antibodies. But the thing is, due to this interleukin 5 tells the B cell to make a special type of antibody. And this antibody is called an IgE antibody. Why is this such a problem? They are now going to be firmly implanted onto a special host cell. Let's draw this bad boy right up here. So let's say here's this is the problematic cell. This is the guy that's causing a lot of the problems here. This cell is called a mast cell. And mast cells can be basically found anywhere around your circulation system. So they can actually be found around it, like perivascular. It can be found in a lot of like our areolar connective tissue. On the mast cell, it has a special type of protein. I guess everything's like predestined, right? Because some people are genetically predisposed to this. But what happens is this IgE antibody plugs right in to this actual receptor here. What is this receptor called? It's called an FC epsilon R1 receptor. That's not a heck of a word there, right? So this FC epsilon R1 receptor binds with this IgE antibody. Now this mast cell is ready. Anytime that person is exposed to that allergen, in this case it could be anything, this allergen, but one of these usually. Anytime they're exposed to it again, they might have an hyperactive immune response to that. So some people, they might just produce a little bit of histamines if they're exposed to it again. But some people might be very, very sensitive, hypersensitive to it. That's why this is a type of hypersensitivity. If they're exposed to the allergen, they'll produce tons, more than normal amounts of inflammatory mediators. So let's say that for some reason they're like, oh, I didn't know. They took penicillin and then they take it again without knowing that they're severely allergic to it. That penicillin binds onto the mast cell. And that mast cell goes ham. And what is that mast cell going to start doing? Let's say that we have the mast cell right here. The mast cell is going to start degranulating, and it's going to start producing tons and tons of chemical mediators here. So here's my IgE antibody. And truly, it takes a couple allergens really to activate this IgE antibody. Usually it has to be dimerized. Anyway, when you activate the mast cell starts producing all these chemical mediators. The main one that's going to be causing a lot of these problems here, we'll mention two of them. One is going to be leukotrienes. This is one really bad one. The other one is going to be histamines. And this is the culprit. This one is really, really bad because they produce a lot of histamines. Why is this bad? Histamines have two big functions. One is they can go to blood vessels. So let's pretend here I have like a small blood vessel here. So there's two things. Let's say here's the smooth muscle because it can act on smooth muscle and it can act on blood vessels and it can act on other different things too. So let's say that here I have a smooth muscle here and let's say here I have a blood vessel. One thing it can do It's actually most affected in the actual airways, within our respiratory system and on our skin. Those are the main areas that can cause this severe anaphylactic shock. What happens is these histamines come over here to these blood vessels, and they bind on to receptors on the blood vessels, and what they do is they'll stimulate the blood vessels to become dilated. And when these vessels dilate and become very permeable, a lot of fluid leaks out. Why is that a bad thing? Let's say it's within this respiratory airway. I took a cross-section of like a bronchial. Let's say that a lot of fluid starts building up out here. As a lot of fluid starts building up in this area, what's it going to start doing? It's going to start squeezing and actually become very, very edemacious, restricting the airway. But guess what? Histamines are like, hey, let me actually come over here, bind onto this smooth muscle within the bronchi. And I'm going to stimulate the smooth muscle within the bronchi to constrict. So now the actual smooth muscle is going to constrict. If it starts constricting, it's going to reduce the amount of air coming in through the airway. What is that going to do? That's going to cause severe respiratory distress. So it's going to cause severe respiratory distress. This is why it's so dangerous, because it can constrict the airways and affect the amount of air that's coming into the individual's lungs. Another thing is that it's actually causing an increase in the actual, it's vasodilating the blood vessels. And why is that a problem? Because when you vasodilate the blood vessels, how does that affect it? Vasodilating the blood vessels decreases the amount of fluid that's remaining within the actual blood vessel itself. So that decreases the blood volume, which decreases the actual blood pressure. Also, as all this fluid is leaking out into the peripheral areas, not only will it cause systemic hypotension, but if you can't deliver enough oxygen to your tissues, they're going to become ischemic. If they become ischemic, they become necrotic. If they become necrotic over a long period of time, the organs can fail. Now, another thing that can actually happen with this anaphylactic shock, not only can it constrict the airways, but it can constrict another really, really important one. If this starts developing, it becomes very dangerous. So it's causing vasodilation, which is basically causing a lot of edema. One of the dangerous ones, it can cause edema here in the larynx. If a lot of edema and swelling starts developing around the larynx, this is causing laryngeal edema. This couldn't be more dangerous, okay? So laryngeal edema. This is bad news. Bad news bears here. Because as the edema starts developing around the larynx and swelling up the larynx, you can't get air in. You're obstructing your respiratory passageways. That is bad. So that can cause severe problems and lead to death very quickly. So what else could happen? If they're having such respiratory distress, right, so they're going to have a lot of respiratory distress because of the constriction of the bronchioles, the fluid accumulation in that area, even around the larynx, where else can it happen? You know, angioedema can develop around the lips too. It can also develop in other different areas, like we said, like the larynx, and even in the eyes too. You can even get a little bit of angioedema, which is just swelling within the eyes. Another thing that can happen is that these actual histamines and other different chemical mediators can come over to the skin. And they can cause a lot of reactions within the skin that can lead to itching. Okay, that can lead to itching of the skin. And it can lead to rashes and hives of the skin. So that's another thing that you might notice within a person going into anaphylactic shock. So what would you notice in anaphylactic shock? You're going to notice the person has a decreased blood volume, like the actual amount of volume circulating within the blood, the actual blood vessel. So they're going to have systemic hypotension, okay? Why? The reason they have systemic hypotension is because the blood vessels are dilating. So the vasodilation is decreasing what? Vasodilation is leading to a decreased what? So if you remember over here, this is the main culprit. Vasodilation is doing what? It's decreasing the systemic vascular resistance, which is decreasing the blood pressure. As you decrease the blood pressure, you decrease the oxygen delivery to the tissues, which leads to hypoxia, ischemia, necrosis, failure. You get it? Now the question is, how would you treat the patient? How would you treat them? You're going to want to be able to give them epinephrine. Why? Because epinephrine is going to come in there and constrict the blood vessels. So if you give them epinephrine, it'll constrict the blood vessels to help to be able to retain the blood pressure. Also, what's the culprit? Histamines. Give them antihistamines. Give them Benadryl. Give them ranitidine, which is basically going to block those histamine receptors where histamine is binding. So that's another thing that you can do. Another thing is you have to really be careful. People who go into anaphylactic shock, you have to monitor them for a couple hours. The reason why is there's a small percentage of the population, like 20%, that after they have their first initial attack, about 3 to 4 hours later, they can have another attack. It's called a biphasic phenomenon. So in certain situations, you do want to monitor the patient. But again, treat them with giving them epinephrine. You can first give them like the EpiPen, like the IM injections. If that's not working, you should get them to the hospital and try to be able to get an IV line set up, so give them epinephrine. And again, put into the IV, give them the antihistamines like Benadryl or ranitidine, which is basically blocking those histamine receptors, preventing histamine from causing all this vasodilation, itching, redness, laryngeal edema, angioedema, all these different types of problems that could kill the individual. Okay, that covers anaphylactic shock. Now for the last one, to finish it all off, is neurogenic shock. Neurogenic shock is actually pretty much what it says in the name. In this situation, the nervous system is actually the problem. So usually what happens is, this is the most common cause of this, is usually an acute spinal cord injury. Okay, so some type of situation where you injured the spinal cord. Now, acute spinal cord injury, or maybe even another one is like if certain people, when they undergo regional anesthesia, they can also develop a neurogenic shock too. But again, the most common type is cause of this is acute spinal cord injury. If you damage the spinal cord, let's say that you damage the main areas here that is delivering these action potentials out to the heart. So remember here we have the vasomotor center, and I'm going to keep it the same color here for the cardiac excitatory center. And it was coming down here, and it was activating these neurons within the spinal cord, right around T1 to L2, right? And what these guys were doing is they were taking information to the heart, to the myocardium of the heart, and to the SA node and the AV node and stuff like that. They were also taking information to the blood vessels. To do what? One thing is it wanted to constrict the blood vessels. So one thing is it wants to cause vasoconstriction. That's a big one. Okay, to constrict the blood vessels, to squeeze them, to be able to increase the blood pressure when you need to. The other thing is it goes to the heart. And when it goes to the heart, it tries to increase the heart rate. It's a positive chronotropic agent. And it's trying to increase the actual contractility, which is acting as a positive inotropic agent. But in some type of acute spinal cord injury, guess what you done? Guess what you done did? You done fricked these things up. You gave them an autonomic blockade. So now you've affected them with an autonomic blockade. Because there's an autonomic blockade and you've damaged these actual fibers that are moving from the thoracic lumbar region to the spinal cord, do you think that you're going to be able to increase the heart rate now anymore? No. So guess what? Remember the vagus nerve? The vagus nerve was actually coming over here and was actually affecting the heart rate too. Guess what? He's unopposed now. So now you have unopposed, holy crap, I couldn't even spell opposed, unopposed vagal tone. Why is that bad? Because this can lead to bradycardia. So in these patients, you'll notice that they're going to have bradycardia. So that's one big thing. Another thing is they're not going to be able to cause vasoconstriction of the blood vessels. If they can't vasoconstrict the blood vessels, what are you going to notice with these individuals? So they'll have a decreased heart rate, and they can't vasoconstrict. So naturally, their blood vessels are going to be vasodilated. What did I say was the problem with these individuals? They have, whenever the blood vessels are vasodilated, this decreases the systemic vascular resistance. As you decrease the systemic vascular resistance, this decreases the blood pressure. That was the problem with all of these. Because you decrease the blood pressure, what happens? You're not delivering enough oxygen to the tissues. If you can't deliver enough oxygen to the tissues, what's going to happen? It's going to result in hypoxia, ischemia, necrosis, and then possibly organ failure if not reversed. So these people are going to have a loss of vasomotor tone. So they're going to have a very low blood pressure, and that's why this can become very, very dangerous. Now, with that being said, how would you treat the patient? How would you treat them? Generally, what you're going to want to do is you're probably going to want to put them on vasopressors. That's probably the big one. You're going to want to give them vasopressors. Okay, so vasopressors is going to be a significant one. And again, you can give them dobutamine. You can give them, so what could you give them? You could give them dobutamine. You could give them isoprenaline. You could give them epinephrine. You could give them atropine. There's a lot of different drugs that you could give to be able to treat this patient, right? Another thing is you're going to want to put them on fluids. So you're probably going to want to use some type of IV fluids, okay, to be able to stabilize their blood volume, bring it up a little bit. Sometimes, in certain situations, they even respond positively to corticosteroid therapy. So sometimes they even do, sometimes you can use it, sometimes you cannot. You could use corticosteroids. So why is that a problem then? Again, if you aren't able to stimulate the heart to be able to increase the heart rate, you're not going to be able to bring it down, and it's going to be, the vagus nerve is unopposed. So now it's going to significantly decrease the heart rate. The contractility isn't going to be able to be increased beyond what it normally is anymore. Also, you can't vasoconstrict the blood vessels, so what starts happening to these bad boys? These bad boys start frickin' dilating. And as they start dilating, it affects the actual tissue perfusion. And as you affect the tissue perfusion, you're not going to be able to get enough blood flow to this actual tissue area. It's going to affect the oxygenation of the tissues, lead to ischemia, lead to necrosis, and then again, the problem is that this can lead to organ failure. All right, Ninja Nerds, I can't say thank you enough, guys. If you guys stuck in throughout the whole video, both series, the part 1, part 2, I can't thank you enough. I really appreciate it, guys. I really hope it made sense. I know this was a beast. I know it was a lot to go through, and I hope it helped. I really do. If you guys did like the video, if it made sense, please hit the like button. Comment down in the comment section, and please subscribe. Ninja Nerds, as always, until next time.